Hey everyone, it's 6 o'clock, so we'll go ahead and get started. Welcome to 2022 as we kick off this year's season of EMSconnect. It's good to see everyone's names popping up. Hope everyone is doing well and is staying healthy. Tonight we got Dr. Travis Dirks presenting on pretty much everything from cardiac arrest all the way onto the ROS-C side of things. So he'll be kicking that off here shortly. Let's just get through a couple of housekeeping things as we get started. First, if you got any questions, comments, episode ideas, anything along those lines, info@emsconnect.org is our email to get a hold of us. Any issues with the platform, the website, anything along those lines, let us know. Our website, if you're not familiar with it, www.emsconnect.org. If you're joining us and you're not a member, feel free to check us out there and reach out with any questions you have. And as always, social media outlets, Facebook, Twitter, Instagram. We promote our podcast, we talk about upcoming episodes, we talk and give notifications when we drop some new content, as well as some fun swag giveaways can be found there. So if you haven't done so, like those social media pages and stay connected with us as much as you possibly can. On the lines of podcast, if you haven't checked out our new podcast, EMSconnect On Shift is found on any of the major podcasting platforms. We talk everything from humor, professionalism, patient care. It's been really, really fun. We've got, I think, 5 episodes currently uploaded into those major podcasting platforms, and 5 more are dropping that first week of February to include our first one with Dr. Dirks on professionalism and burnout. And I will tell you, after listening to it, it is a phenomenal, phenomenal listen. About an hour and a half long, and I think it'll change the way that you practice EMS as well as be a member of your family as well. So check that out if you haven't done so. Download the content, share it to spread the word if you would, please and thank you. As always, here in a little bit, I will randomly select someone from our participant list for our $50 Amazon gift card giveaway. Don't have to be a member of EMSconnect, just have to be logged on for this lecture. We will notify you via email as well as post it on our social media site right after the presentation has ended. So stay tuned for that. The last real housekeeping thing is we always throw our disclaimer out there because what we talk about is never protocol driven. This is about, could be new concepts when it comes to patient management, transportation, medication recommendations, anything along those lines. So we want to make sure that everybody attending and listening, you got to follow your approved local or state protocols on patient care and transport. Now, if you have something you'd like to take from one of our presentations and take it to your medical director, all of our faculty physicians have really great experience when it comes to working with agencies, including some of them are agency medical directors. So if you have questions, shoot an email to that info@emsconnect.org. We'll get you connected with whatever physician can help you out. And I know they're more than willing to give you guys resources and documents and anything along those lines to get you guys taken care of taking some of this education and providing it and making some changes within your agency. As always, I'm your host for EMSconnect. My name is Sean Pitts. I'm an advanced EMT and firefighter here in Spokane County. I'm the head of education and kind of work on the BLS content as well as facilitating our speakers. So hope you guys enjoy tonight. I'm going to turn it over to Dr. Dirks and let him give his introduction and go ahead and get us started.
Hopefully everybody can hear me all right. Yes, I'm Travis Dirks. I'm an emergency physician in Spokane, Washington. I work at Sacred Heart Medical Center. I'm also a medical advisor for a couple different agencies around here that traverse the EMS spectrum from BLS, first responder, to paramedic level. So I'm comfortable talking with, working with, going through case reviews with any level, and definitely understand the troubles that each level can have from rural to urban EMS care of patients and kind of the interesting difficulties that come into play when you're talking rural transport of patients at the BLS or first responder level. And I founded EMSconnect back in 2012, and it has turned into something fun that I definitely enjoy doing. And I have missed presenting for quite a while. I used to present every month. Sadly, I'm sorry for those of you who have heard my voice many, many hours in the past. I miss doing this, and I'm looking forward to playing again today. So I selected cardiac arrest as the topic I wanted to go over with you this evening because it's something I'm actually passionate about. When I first went into emergency medicine and got excited about EMS stuff, cardiac arrest is kind of that pinnacle, right? that we all get really excited about because we feel like we could get a save or get that ROSC or get somebody back, save a life. And when I first started my career in emergency medicine, getting ROSC and doing cardiac arrest were this really high anxiety situation that I'm sure a lot of you feel. And what I hope you eventually turn into is the type of professional where a cardiac arrest scenario doesn't frighten you at all anymore. And you might kind of scoff at that and go, come on, everybody should be a little anxious and frightened in it. But really what I want you to realize is that in a cardiac arrest scenario, there's not a lot of outcomes if you think about it. There's so many things where if you gave me a patient with an acute aortic dissection who was super hypotensive and I didn't know if they're going to live or die, they could be circling the drain, or a sepsis patient who's circling the drain. I'm much more anxious with those cases because what I do could cause problems. I could screw things up. I might miss the diagnosis. I might not treat something in time and I could lose them when I shouldn't have. So how I want you to think about a cardiac arrest scenario is it's already as bad as it could get. If you wouldn't have showed up, the patient would be dead anyway. So whatever you do on scene is most likely a positive thing. It's a good thing. It's great that you showed up. And anything you can do in a professional manner is a win. So you've already won just by showing up. And so what I hope this turns into is a much less anxiety-provoking scenario for you as a provider who can show up and think, cardiac arrest scenarios are very cookie cutter. There's step 1, 2, 3, and as long as I do those steps, I'm going to provide good care. And I want you to get over that feeling of patients could die. Everybody will die. I'm going to die, you're going to die. Hopefully down the road a ways. But the reality is if you wouldn't show up, natural biology is that this patient is going to pass away. And so some of these cases can be very difficult if it's a pediatric arrest or a young adult. But a lot of the cases we come on scene for are cases where this is a natural progression of life for that patient, whether it's a long-term cancer patient on hospice, whether it's an elderly patient with that heart attack. And what I want you to walk away from this talk with is it's not about ROSC at all. It's about the positive you can do by showing up. And sometimes the positive you can do is not a whole bunch of medications and chest compressions for an hour and all these shocks. Sometimes the best you can do is talking with the family while your partner's doing the resuscitation and compressions. Talk with the family and guide them through the situation and express to them that this is a natural thing and that this is likely that person's time to pass, and potentially walk with them and go through the scenario of, you know, if they've been down for a certain amount of time, the likelihood of brain damage is quite severe. And so the positive you can do on scene is not always ROSC, and most of the time I would argue that it's not. The positive thing you can do on scene is just provide patient and family care. And so this image of a fast, cool car and cardiac arrest is actually a farce. It's not about that anymore. And as we go through this, I hope that you understand that it's not about the fast, cool stuff, and we're going to get back to basics. So we're going to throw in a couple of questions because I want to gauge where you are in this journey.
So we got a couple of questions here just to kind of get everyone's mind going here. So our first one is true or false, really straightforward. Epinephrine is included in ACLS protocols because it is linked with survival and good neurological outcome. And we'll close it right there. Travis, here is what we got, sir.
Oh, good. That's exactly what I was hoping. A real mixed bag. The answer, obviously, and will come up here, is it's false. Okay, and we'll talk about that as we go through it. The next one. Okay, paramedics and the meds they give are the only factors that improve changes for ROSC with good neurologic outcome. Is that true or false? And don't be ashamed if you get these wrong. These are just kind of me gauging the audience, see what's out there.
This one you didn't get nearly as many people to bite on the true side.
That's as expected. Good. So good. I'm kind of setting you up for how this talk's going to go. And I hope that with it, we empower the BLS out there to feel much better about who they are and what they do. So this is the real title slide of this talk. It's not the fast, cool stuff. It's not all the neat technology and the medications we have. What I want to express to everybody listening to this and in the future is This is about getting back to basics. It's not about epinephrine. It's not about all this cool stuff we have available in IOs and intubating and video laryngoscopes. And it's got nothing to do with all of that stuff. And we'll talk about the things that really matter as we go through this. And sometimes what really matters is that just that you showed up and you're going to be positive and professional and help guide the family through a really tough situation. So let's move on with question 3. Take it away, Sean.
So which of the following EMS skills are the only proven factors that improve rates of good neurologic outcome in cardiac arrest? A, rescue breathing and oxygen. B, intubation and chest compressions. C, epinephrine and defibrillation. Or D, compressions and defibrillation. Here you go, sir.
Excellent. Good. So we're where we should be, and that everybody's aware that the only two things that equate to resuscitation and a good brain after you almost died is quality compressions and early defibrillation. So thank you for answering that appropriately, and let's see what the rest of us can learn from this. So what the heck exactly is a cardiac arrest? So let's get down to the basics of cardiac arrest. The gist of it is that the heart is stopped. Cardiac arrest. Arrest means stop. And the heart can stop for lots of reasons. We'll talk about a few as we go through this. But what I want everybody to get here is everybody's so focused on the heart. We're going to push on the heart. We're going to give all these meds for the heart. We're going to do all this stuff for the heart. But really what we care about is the brain. The brain needs the blood flow. That's what the heart's for. It's pumping blood to the brain. So the brain needs blood, which is carrying oxygen. So if we are not pumping that heart, our brain is not getting oxygen, and that is what really matters. Because the heart, if you take one out of a live human being, it'll keep beating on its own. We can get a lot of patients back with ROSI. If you pound on a heart long enough, you're going to probably get ROSI. That's why a lot of people will take a resuscitation probably a bit too far and go too long, because they know if they just push long enough and do things long enough, they probably can get a heartbeat back, and then you get ROSI, right? And that's what everybody's so proud of. I got ROSI back. Well, I challenge you, the next time you get ROSI, follow that along and see how was the neurologic outcome? Did they survive to hospital discharge and walk out at 30, at 30 days, how are they doing? And so for me, I used to get really hung up on ROSI, and I wanted to get that heartbeat back, and boy, if I got it, I felt like I was amazing and I just saved the day. But then I found out that a ton of my patients were getting their heart back and never left the hospital. They died in the hospital after family had to pull the plug days later or a week later. And so what did I really do there? I got a heart back because I could, because I knew how, if I gave enough medications, if you get enough epinephrine and that kind of stuff, you can probably get a heart to beat again. If you push on them long enough, you can probably get ROSI back. But I was not seeing that real good outcome that you really want to measure. Is they walked home and saw their family and hugged their family again and knew who they were. So the brain activity is what we really care about. ROSI is just a way of kind of measuring, did we get them back to maybe having good hospital discharge? But sadly, if you follow your patients along, the vast majority of resuscitations don't leave the hospital, or if they do, they have significant brain damage. So we really want to focus when we talk about cardiac arrest and resuscitation on brain perfusion. So that is the big deal. So why do people actually go into cardiac arrest in the first place? Well, let's separate our different patient populations into pediatrics and adults. So in pediatrics, we all hear about through our training that it's all about the airway and breathing in peds, and that is true. In pediatric cardiac arrest, very rarely is it heart related, because if it's heart related, it's usually due to a congenital heart disease. And those patients are very rare and pretty well known at the time. And they're either going to pass away right after birth, or they have a known heart disease condition that you're going to be made aware of right when you show on scene. So the vast majority of pediatric cardiac arrest is due to a respiratory issue, likely an airway obstruction, that classic toddler playing with Legos or a toy and is suffocating, turning blue, or some sort of hypoxic event, whether they're ill and that kind of situation. So when you come on scene with a pediatric cardiac arrest, it's all about airway and breathing while you're doing your compressions as well. So this is where we kind of break that rule of don't worry about the airway, and we focus a lot on the airway with pediatric resuscitations. And not much has changed with this in a long, long time. You still check for an object in their mouth, you give 2 breaths, and then you start your 30 and 2 cycles. There's not a big change there. Now, personal caveat. A pediatric cardiac arrest is one of those rare situations where I might not have you call it in the field. If you call me online for direct medical control on the phone, I have such a hard time telling an EMS provider to call a child dead in the field. The rare situation if they're a known congenital heart patient and they're on hospice and it had a known low lifespan, low chance of survival, sure, I may have you call it in the field, but odds are I may actually break those rules. God forbid we break rules, right? And say, go ahead and transport with resuscitation in progress, even with compressions, because it's pediatrics. And that's a really touchy subject. And that's not the kind of thing I expect EMS, especially BLS first responders, to call in the field and talk with family and deal with this. So it's one of those times, because I do EMS and know the situations you were all put into, that I may actually say, go ahead and transport that. But these are tough situations. We never like these. I hate these. That's why I don't really do peds anymore, peds ER, because I couldn't handle it. It was something that I just wasn't prepared for. And people like my wife and the pediatric ER doctors out there, they are absolute angels, because I can't do this. It really cuts to my core and I can't handle it. The classics when it comes to adults, that's where I love, adult resuscitations, is classic stuff like heart attacks, heart failure, sudden arrhythmias. And those arrhythmias can come from lots of different things, from even sepsis to pulmonary emboli to a medication or a drug effect can cause an arrhythmia. Aortic dissection or rupture. Aortic dissection or rupture are those big classic ones that typically kill you that day. And these are really tough patients to keep alive long enough to get their aorta repaired surgically and survive with good neurologic function. Pulmonary embolism we hear about, that's that blood clot in the lungs. Usually it comes from the leg, travels with the flow, technically downstream, but it's going up against gravity. It just flows in the venous system, returns to the heart, flows right through the heart, and gets stuck in the lungs that act like giant filters. And if you have a small blood clot in the legs, you might not even notice it. You may cough, get a little chest pain, might have a cough for a few days and never realized it was a blood clot in your lungs. If you have a big blood clot in the leg and that thing travels to your lungs and blocks a huge pulmonary artery, you're talking sudden arrhythmia and death. Pneumothorax, typically obviously from trauma, or COPD patients, asthma patients can have a sudden pneumothorax, a tension pneumo. So traumatic situations can cause cardiac arrest, but let's be honest, if you have a cardiac arrest from a trauma in the field, whether it's a car crash, a gunshot wound, the chance of you getting that patient back in the field with active resuscitation is darn close to zilch, okay? Because they have penetrating wounds that have damaged enough that it's going to be really hard to get them back in the field if they're already in cardiac arrest and their heart has stopped. The rare case of like a pneumothorax, you might be able to needle decompress and treat the tension pneumo. So it is possible and still do your job professionally, but those are really tough cases to get back in the field. Apnea just purely means not breathing. This is something we see in pediatrics mostly. Overdoses, think young people, anybody who has kind of a weird story around the cardiac arrest, found in a bed, not breathing well, turning blue, and there's an empty bottle of something or an empty prescription bottle. Then think overdose. And those are hard patients as well, because some of the overdoses make it so it's really hard to get heart function back. Like the beta blocker overdoses are just terribly hard to treat and resuscitate adequately. Potassium hyperkalemia is always a big problem. We think about that a lot with renal patients. And then sepsis and anything that causes multi-organ failure or shock states, anything that causes shock, whether it's hemorrhagic shock, hypovolemic shock, septic shock, any of those are going to be big things for causing cardiac arrest. Now, let's talk about the natural progression of when you come on scene and some of the weird rhythms you might see, because there is a natural progression to things. And this is anecdotal. I can't provide science to back this up, but this is after 17 years or so of emergency medicine care and watching people die, not intentionally, I try my best. But the rhythms you typically will see, let's say a patient has a sudden heart attack. A typical scenario for a sudden heart attack is that they will go into ventricular tachycardia or ventricular fibrillation. If they're awake, it's got to be ventricular tachycardia. Now, the longer they sit there with their massive heart attack causing VTach, the more likely their heart's going to say, I'm tired of this crap. I'm done doing this. I'm exhausted from VTach. And they go into VFib and quickly progress to asystole. Because in VFib, your heart's not beating, your brain's not getting oxygen, and you go bye-bye very quickly. And this is why EMS is so critical, because if you have a good response time and you can get to that heart attack patient within that short time frame. This is why we always look at the like call to arrival intervals and how fast you get involved and get in a rhythm strip or a 12 lead. It's because if you get there quick enough, you can catch that heart attack patient within that short window where they're still maybe in VTAC, maybe they're even awake in VTAC, or if they just went unconscious, they're in early VTAC or VFib, and you can still shock them out of it, and you shock them once and they wake up. And if you've ever been involved with those cases, they're really fun, if I can use kind of a weird word. I think they're really fun cases because you know what's happening. The patient's heart is trying to die on you, and if you just apply your patches and get ready to shock them again, you're just going to keep saving them over and over and over. And it's really weird, but if you get used to it and know what you're doing and get comfortable with the idea of the heart's trying to die, my job is to kick its butt when it goes back into a bad rhythm, and I shock the patient whenever they go back into VTAC or VFib, I can bring them back. And that patient just needs to get very, very quickly to a cath lab. So the natural progression of VTAC and VFib is to go into what we see here at the top, asystole, that flat line. And so this patient, if you come on scene a little late in the game and they're already unconscious with no pulse, they could be in a flatline asystole type rhythm. Whereas the patient down below, this patient likely doesn't have a pulse, and the natural progression of PEA is that they had some sort of illness, whether it's sepsis or maybe even a heart attack, it just caused a different rhythm, and they became bradycardic, really, 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 really slow, and they got so slow to the point where that they lost pulses, and they still have those once in a while beats called PEA, pulseless electrical activity. And so while the top person will pass away and you could call their code with asystole, the bottom person, you might actually call their resuscitation at time of death and they're still in PEA because the heart has that innate electrical rhythm and continues to want to fire electricity even after the patient is dead. We always talk about the 5 H's and 5 T's of PEA, but really I would use these for a lot of reasons people have cardiac arrest. And so I wouldn't just limit it to PEA. This is things I go through with any cardiac arrest. I think about these really quickly just so I remind myself not to miss something. And I won't go through each one. The big ones here are the hyperkalemia, hypoxia. In the T's, we obviously have trauma, and then we have the cardiac tamponade, which honestly is mostly trauma too. Tension pneumo is a big one, and then the thrombosis is basically the heart attacks, means myocardial infarction, that MI at the bottom right, and pulmonary emboli. So both of those are the clots. Thrombosis means clot. So the 5 H's and 5 T's are good to know. Do I expect you to remember them? Maybe for a test, sure. But in real life, during a resuscitation, no. I'll be honest, I don't remember all of these during every resuscitation, which is why it's nice to have written protocol sheets that you pull out during a resuscitation that have them on there to remind you. Why make your job harder? Make it easier. Let's talk a little bit about science. And for those of you who like movies from the 80s, this is one of my favorites, Weird Science. This is a great, stupid show you watch the next time you just need to chill out and decompress. This is a great graph. It's not perfectly accurate. Obviously, nothing is 90, 80, 70, 60 perfectly like that. But the gist of it is that this gives you a great concept that when you come on scene of a patient who has gone down and are pulseless, if you arrive there and actively start pushing on their chest within 1 minute, they have a chance of survival of 90% because it's only been a minute since they lost pulses and their brain is still okay for a short while. But you can see there as the minutes go by 10 minutes without somebody pushing on their chest or defibrillating them, their chance of survival is less than 10%. It's a 0, okay? 10 minutes, 0. So the next time you come on scene of a cardiac arrest and the family tells you they went down and it was 8 minutes ago and nobody has been pushing on the chest, nobody's defibrillated the patient, you should already know that my chance of survival in this patient is less than 20%. Whatever I do, as long as I do the things I'm trained to do in a nice, orderly fashion according to the checklist, I did a great job. I don't have to worry about anything. I'm just going to show up and do my job, okay? Know my role and do my job, and know that by the statistics, the chance of you getting this patient back and them walking home is almost zero. And so just show up and do the best you can and let the anxiety of the situation go. If you show up and it's been 3 minutes, you just do the same thing. You do what you're supposed to do in each cardiac arrest in order. And if you get them back, great. If they have neurologic outcome, that's good. That's fantastic. But I want you to get rid of this stress and anxiety of a cardiac arrest and grasp the concept of, I'm going to a situation that is so cookie cutter, we can make checklists for it. And if I show up with my 2 people I'm on shift with, and each of us knows our role going into this, and we just do our job, nobody has to walk away stressed. The situation can be quiet and not chaotic. And it can be something you actually start to enjoy the heck out of in your career. I like cardiac arrest scenarios. I think they're fun. I think they're cookie cutter. I think it's a great time for people to evolve as professionals. Let's talk about why I get so ticked off when I hear about people not pushing on the chest constantly. So this data came out back in 2012, you can see there at the bottom, and it was from the American Journal of Emergency Medicine. And really what this is showing, don't get stressed by graphs. Really what we're looking at is the green on the left is I'm doing compressions consistently, and I have good brain perfusion, which is what we care about. So good continuous compressions. And then right there in the middle, the compressions halt, where it turns from green to red. And what's happening there is this is a graph of your brain's blood flow. Once you stop pushing on a chest, the blood flow to your brain completely stops and it drops, plummets to a non-perfusing flow. Your brain now is immediately lacking oxygen. And I don't know about you, but if you hold your breath for a short while, you feel it, right? I mean, a short while, less than a minute, and you're miserable. So think of the last time you're on a resuscitation. Let's say you had a paramedic there, and the paramedic says, okay, halt compressions, I'm gonna get the tube down. When was the last time it took less than 1 minute? Probably for most of you out there, you're thinking, most of the time it's several minutes, okay? And if you actually time this out, they have studied this, it's a lot longer than people think when you're intubating. And I'm to blame as well. When I was first in training, I would intubate thinking I was a speed demon, I was like a Ferrari. And when you actually go back and look at it, it takes a lot longer than you think to intubate because you're there, you're looking, you're going slow, putting your tube down. And so it's a pretty good amount of time. During that whole pause in resuscitation and compressions, the patient's brain flow has completely plummeted. The bad thing is that now when you start pushing on their chest again, it doesn't just go back up to that nice green zone on the left. It's a slow trend up like you see on the right. And so it takes another period of time to get their blood flow to the brain, the perfusing oxygen to get back to normal. And so the next time you're on a resuscitation, really start thinking, what does every one of these little pauses do to the chance of survival for this patient? Not just chance of survival, brain function. What is every little pause doing to my brain function outcome? And when everybody's so focused on getting the heart back and getting Rossi, I want you to start focusing on what are we doing to his brain flow right now? Push on his chest. Stop messing around, stop wasting time. You're taking too long intubating. We're going to do compressions during intubation. If you don't like it, don't intubate, okay? Compressions are key to get flow to the brain. And that's something that a lot of paramedics these days, I'm finding out, are just kind of missing the concept of. Everybody's so focused on the stupid tube, they forget the point of everything of why you're there. And why you're there is because the heart's not beating and the brain's not getting flow. So please, please keep pushing on the chest. So this is what happens every 2 minutes when we used to do those long rhythm checks. Every 2 minutes, rhythm check, and we're waiting 10 seconds. Is there a pulse? Hey, do you feel the pulse? Is there a pulse? Anybody get a pulse? And we've just completely destroyed all of that effort we put in all along this time. And now we've got to build that all back up really slowly with compressions. And then we pause again and let it plummet again. And so this is what we used to do. And what we should start doing is this: continuous compressions during the entire resuscitation until you get pulses back or until you call it. And I would challenge you out there as paramedics, the ones listening to this saying, oh, dude, you're going to take away my tubes. I challenge you, don't have people pause during compressions for anything you do. Okay, let's try continuous compressions aside from your 2 minute. 1-second rhythm check to see if there's a pulse. And as we go through this, I'm going to teach you ways that you know immediately if there's a pulse. And then question 4, take it away, Sean.
Real quick, Travis, a couple of good questions here. The first one is, can it be dangerous to intubate while chest compressions are happening?
So they've looked at this, and the whole concept is, could we cause a pneumothorax while we're intubating? The reality is you can push all day on the chest as somebody's trying to pass a tube down. That's not going to cause a pneumothorax. The difference is if you pump a bunch of air in there while somebody's also crunching on the chest, sure, you could always pop a lung, which is why you should try to time it with compressions, recoil. However, the only damage that I can potentially foresee while trying to intubate while doing compressions is just the teeth or the airway if somebody's moving around like this with a tube. And so if that's the case, maybe you don't need to be intubating right now. For the paramedics out there challenging me going, so you're telling us not to intubate a cardiac arrest? Yeah, I actually am. You can record this and call me out on it. It will be recorded. I'm challenging you that if you don't have a pulse, why? Why is intubation the first step? Do good quality compressions. And if your answer is, I'm going to only cause a pause just for a short while to intubate, that immediately goes against everything right now. Where in the EMS literature is it ever saying it's okay to halt compressions to pass a tube? Send me the literature, show me.
Yeah, and here's the other one. This one's really good, and I think after our talk on professionalism, this is a real good question. We cannot override a paramedic's order. What can we do as an EMT to prioritize compressions over intubation? I feel like we knew this question was coming.
Oh, sure, of course. So resuscitations, we all know it. These are high stress environments. At least we make them high stress, right? And we also get way too many cooks in the kitchen. How many times have you been on a resuscitation in an urban environment where there's more than one medic on scene? And then it's who's running it, who's the boss. And we just had we did this podcast this month about professionalism, and I specifically went over working with each other professionally on scene, okay, and how to be a professional. And the reality is if there's a paramedic on scene or any higher level of care, and they are taking over patient care, okay, that's great. We want a hierarchy on scene. There should always be a hierarchy on scene, just like any major corporation or military unit. There's always a hierarchy, and it's how we follow procedures and protocols and not get this chaotic nightmare of a situation. So my response in that scenario is if I was that EMT, let's say I'm an EMTB, and I'm in a situation of a resuscitation where I have a paramedic working on a case and the paramedic wants to intubate while we're actively doing compressions. Okay, the paramedic is calling the shots, they are the higher level. If they say this while we're doing compressions, number one, I never argue in front of family, period. That is like hands down rule. If you ever argue in front of a family, you've already failed that family miserably and they're gonna think you're all idiots. And so don't ever argue in front of family. If there is no family present, if I was the EMTB, I would professionally say, are you sure you want me to pause compressions for you to intubate, or do you want to wait until we get pulses back? Because if I pause compressions, that's definitely shown to be a really bad move. And I would put it like that, of like, I'm voicing my concern to my higher level of care, and I'm not being a jerk about it. The goal is not to like one up each other and go, I read this latest literature and I'm really smart and you're not. That's a terrible thing. That's so unprofessional, not cool. Be kind to them, okay? Assume you're working with a brother or a sister on scene. Hopefully you get along with your brother and sister, and you work as a partnership, okay? It's your spouse, it's your partner, it's somebody you're working there with a common goal. And so if you are having those situations where you feel like there's a better way to do something, you just bring it up in a professional manner. And so I always harken back to treat others how you want to be treated and just be a pro.
Yeah, and here's the last one, just because I think you stemmed a lot of really good questions on the whole advanced airway versus supraglottic airway. So you probably know where this one's going, but you take a look at like the PART trial and the Airways 2 trial, where they were talking about SGAs have been shown, your eye gels. Some agencies might be using King Air or something along those lines. Do you personally, like as an ER physician, have any thoughts on running the entire cardiac arrest with just that supraglottic airway?
Perfectly fine. And interestingly, in the second half of this talk, I'm going to talk about a really interesting study and the results of it. I don't want to give it all away now, but please, if at any point during this talk you're like, this is getting boring, I want out of here, please stick around for a couple of the little resuscitation articles we're going to talk about in the second half, because there's some really interesting data. But yes, I'm going to hold off on that, but say, yes, it's perfectly fine to put a supraglottic airway down.
Perfect. So let's, as we gave plenty of people to attempt to Google this question to see if they can get it right, because I don't know if anybody even has this knowledge in their brain, but in blank, German researchers used chest compressions to revive patients. And so this is kind of like the first time chest compressions were used. So are we talking about 1806, 1891, 1850, or 1734? This one was just kind of for fun to see what everyone, it's been up there for a while. I'm sure some people, while we were talking, were Googling it and seeing what they could find, but we will see here. Dr. Dirks, did you know the answer to this question?
I had no idea.
Like the majority of people got it right.
So let's talk a little bit about pit crew. Okay, pit crew is really a tough monster to crack because every crew is different. How are you supposed to have a pit crew when, you know, station 1 has 3 people on shift, station 2 has 4 people on shifts, and station 17 has 18 people who show up to your resuscitation? So the pit crew template, when I talk about this with providers, usually I'm talking 2, 3 people, and maybe a paramedic shows up, maybe maximum of 5 people. Honestly, during a good resuscitation in the ER, I will kick people out of the room, because one major rule I have is I cannot stand if it's getting loud in a resuscitation.
I'm gonna take the car into the shop tomorrow.
You mean your lame Dodge Stratus?
You don't talk about my car that way. I drive a Dodge Stratus. You don't talk about my Dodge Stratus that way. You do not talk to your father that way. I'm a division manager. I can do 100 push-ups in 20 minutes.
I think anybody who teaches that the loudest person is in charge is a total ass, okay? That's like old school trauma surgery mentality of the loudest person in the room is in charge. BS, okay? The quietest, calmest person who's running this code is in charge. And if people can't hear the leader running it, they need to shut up or get out. That's my opinion, and frankly, I think it's a good one. So the pit crew template is really just something to get you started as a group. If this is not something you're doing yet, please formulate something at your local department, what works best for you. This is not a rule. The things I'm going to teach is not like this is how you do it in the only way. Find what works for you based on your crew and your resources and how you show up, how many people you have. And so really the way to do this, I would say, is let's assume you have 3 people responding at any time of day at your local facility. So if I had 3 people on my crew, one of them has to be the code leader. And that code leader does nothing more than puts a finger on the pulse, the femoral pulse, watches the monitor, goes through the checklist, and thinks. They do nothing else. The pit crew or the code leader should be a thinker. I'm feeling the pulse. By feeling the pulse, even with my eyes closed, I can tell if the guy doing compressions, guy or girl doing compressions, is good. I can tell you that one person to the next is worse at compressions just by feeling a pulse with my eyes closed. And then you add in that I can see the monitor and the rhythm. So now when you stop compressions, me as the code leader, I know the second you stop compressions if there's a pulse, and I can see the monitor and I can say charge and shock, or I can say continue compressions because there's no shockable rhythm and I don't have a pulse. It took less than a second because my hand's been in that pulse the entire time. I know where it is. I know how good your compressions are. And when you stopped, there was no pulse. Continue compressions because I don't see a shockable rhythm. So that's all the code leader does. That's their whole job, is process and think. And if you're running a code, the next time you're running a code and you step back and you get to be that code leader, know that you have no other job to do. You're the thinker. You're the what's next. I'm going to get some information while I'm feeling the pulse from the patient's spouse, find out what happened, process what could be going on, go through my 5 H's, 5 T's, run my checklist, make sure everybody's doing a good job. Okay, you don't have to do anything else. The other 2 people show up. One of them gets on the chest immediately. That's his job. That's their job. They know that with the second we get there, check a pulse, no pulse, I'm doing compressions. I just bought myself 2 minutes as a code leader because person 1 is on the chest. Done. We're doing compressions. That's all we need to do. If I was showing up alone, that's all I'm going to do is compression only CPR. So I just bought myself 2 minutes because person 1 is doing compressions. My next person, person number 3, is the backup to person number 1. Okay, so person number 3 shows up, the backup. They can set up the monitor. They can maybe get a bag valve mask ready in 2 minutes. And at 2 minutes, they take over and flip with the compressor. And then the compressor bags for a bit, maybe throws a supraglottic down, I don't care. But at 2 minutes, they're flipping and doing compressions because I'm checking pulses the whole time. And I know the second they stop if there's a pulse or not. And so get those roles figured out way before you actually have a true resuscitation, and go through it over and over and over at your local facility and find out. Maybe your BLS provider loves running codes and they're totally fine calling the shots, because any BLS provider can run a great code. It doesn't take a medic at all to run a great code. And just like physicians, medics can get very focused, hyperacute focused on the endotracheal intubation or an IV and epinephrine and all these meds, and they're kind of thinking at that higher level and not focused on the more mundane but the more valuable skills you need to do. And so find out at your local area. Maybe your young, new BLS person is just a great leader and can run a checklist and feel a pulse and run a code and be a good thinker. And they're not the big doer. They don't care about maybe doing the bag valve mask or setting up the defibrillator. And so it doesn't have to be the highest level person as the code leader. So you got your immediate compressions, you got your pads on, and then you're just basically doing your 2 rounds. And at no point do those 3 people need to worry about passing a tube. At most, the one who's not on the compressions can bag, okay, take a break and just do some bagging with a mask. And then at 2 minutes, it's their turn. They should be at the chest ready to go, because there should be virtually no pause in that pulse check. And really, it's that simple, okay? People just make it too damn hard. So one big rule I have during resuscitations, or really any time in your career or your job, and this could be with any case, okay? It doesn't have to be just a cardiac arrest, is know your effing role, okay? This goes for everybody and includes me. I just gave this example when we did our professionalism talk the other day. I'm an emergency physician. I'm trained to do a lot of really cool stuff and procedures and cutting. I can cut out a baby if I had to in a trauma in a pregnant female. I can do a lot of stuff. I'm trained to do a lot. So I think I'm pretty awesome, okay? However, if you send me a stroke patient right now, when I'm on shift at Sacred Heart, which is a stroke facility, do you know what my role is? My role is basically to get to a computer and to enter orders for the stroke neurologist, because we have a higher level of care at our facility. And to every stroke, we have a certified stroke neurologist, like the highest level neurologist to deal with stroke. And so when they show up in the room, what am I going to do? I mean, if the patient needs an airway, sure, I'll intubate. Fantastic. I got to do something. I got to play. But I know my role. I know my effing role when that stroke patient comes in. My role is to be that person's scut monkey. I can accept that. After 17 years and being a professional, I can accept for the system to work properly and for this patient to have the best possible outcome. I need to just get to a computer and enter the orders for the neurologist as fast as I can, because they're busy saving the patient. So the same goes for you. Know your effing role. If you show up on scene and you're a paramedic and there's another paramedic on scene already and they're running the code, it's their scene, here's how I want you to show up. Hey, I'm Bob. I'm a paramedic as well. What do you need me to do? That's it. It's not, hey, I'm Bob. Yeah, you haven't given epinephrine in 2 minutes. I'm going to critique you, and I'm going to be a Monday morning quarterback and armchair this, and I'm pretty cool. Now you're useless. Get out, okay? So know your role, please. If you're a BLS provider and paramedics show up, your role might change. You might have gone from code leader to now you're an assistant, and you need to do what that paramedic needs you to do. If at any point at any level you feel like somebody's actually going to cause harm, by all means, speak up. There's a hard stop with any medical case where if you feel like they're about to cause harm to a patient, you do a hard stop and say, I'm not doing that, or you need to stop. We need to do a hard stop, everybody. I don't think this is the right thing to do. Okay, you have that power, you can do that. And then depending what happens, you just document it, but still stay a professional when you do it, okay? So know your role. Be a good helper if you're a helper. Be a leader if you're a leader. And if you don't like being a leader, you can turn it over to somebody else. You don't have to be the leader unless you're the only one there. And so constructive feedback is fantastic. And if you're not the type of person who can take a critique and constructive feedback, then you shouldn't be doing this job, number one, and you definitely should never be a leader. And anything else other than constructive feedback, you should be kept to yourself and you should keep your mouth shut. Okay? Let's talk a little bit about options during these, because there is no hard and fast rule of a pit crew where you should be. So if you show up, I have the leader there, the leader's in that little teal color. And why I have the leader on the side there is because I want the code leader to be at the femoral artery with literally their finger on the femoral artery during the entire resuscitation. And by entire, I mean from the second you get there to when that patient is transported away from you and it's not your case anymore. So if I'm the code leader, I have a finger on the patient's pulse the entire time until I leave that scene or that room, because I can then document and know when they had a pulse, when they didn't have a pulse, who did compressions better. I can actually help teach the person doing compressions because the person before them maybe had better pulses. I'll teach this next person, your pulses are a little weaker than the last. I need you to maybe go deeper or allow more recoil. Okay, that's better. So you can actually help teach people how to do better resuscitation and compressions. So besides the code leader, that person can see what everybody else is doing. You're not on the same side as the compressors. The monitor can be wherever you want it to be, but I find it to be best at the foot of the bed out of everybody's way, where the code leader can look down, see the monitor, look up, see the airway people, look right here and see the resuscitation compression people. You've got two compressors. Those compressors need to switch every 2 minutes. I don't want anybody ever doing compressions over 2 minutes. It gets really inefficient, very poor quality, enough so that you're not getting brain perfusion. So don't be that person who's like, no, dude, I'm good to go. I can go 4 or 5 minutes. No, 2 minutes and you're done. Flip it. You're going to need the break. If you start to have extra people, including a medic, this is where things can get more interesting, okay? If the medic shows up, they don't have to be the code leader. Don't put them in that position if they really want to get an airway in place. If they want to give some medications, that's fine. But if you're a medic and you show up, you should be aware as a professional that people are looking to you to be a leader, okay? And so maybe your job shouldn't be right off the bat, I'm going to get on the floor by the patient's head and I'm going to take this airway. People are looking to you to take control of the situation. They're looking at you as the person who has more education, more training, and knows what to do in these situations. So maybe the best thing for you when you show up is to take over as the code leader until you can make sure everybody is functioning at a job where they're being successful and you have it running how you want it to run, and then you can do your airway. So that's just my personal opinion. Call me wrong. I don't care. It's fine. Let's talk about recognizing when you get Rossi back, okay? Doesn't mean brain function. Remember, this is just, okay, we got a heartbeat back. Number one could be a spike in their end-tidal CO2, and we'll look at some end-tidal CO2s a little bit later. If you get a rhythm change on your 2-minute check, if you just see a rhythm change on the monitor, that might be that you actually have some cardiac function again. Definitely check that pulse again quick. Palpable pulses, duh. And obviously signs of life. If the patient starts punching you for pushing on their chest, they might have a pulse again. Some things to remember post-resuscitation. Once you got pulses back, getting a good thorough history and an exam done is a great first step while you have some time. Get an initial set of vitals, see what's going on. The patient very well may go back into cardiac arrest scenario and lose pulses again. So now is your time to keep your finger on the pulse while getting more information, getting some vitals, you're doing a good exam. If the patient is totally unconscious and not breathing well but has a pulse, now is a great time to intubate them, right? That's the next step, airway. And so if you do intubate, we usually have a collar, a cervical collar in the protocols, and that's not so much for the C-spine injury or anything like that unless they had a big fall. It's just because we don't want their head moving around with an endotracheal tube down during transport. And it's just to help keep the tube in good position so you don't lose your tube. Hyperventilation post-resuscitation is generally a bad thing. Remember, oxygen is a drug like anything else, and we just want to provide the oxygen we need to provide. And so if after resuscitation, your saturations on endotracheal tube with 100% are 100% sats, most people go, oh great, we're at 100%. you don't really want 100%, because what if you're hyperoxygenating and actually causing harm with too much oxygen? How about we shoot for 98%? That sounds like a great goal. 98% sounds fantastic. So what if we're at 98%? Well, start turning down your oxygen if you're at 100. Start titrating that oxygen down, seeing if you do need it all. Maybe you just need 50% oxygen to keep them at 98. And so start titrating the things you can. And the goal after resuscitation is not to just throw the kitchen sink at everybody, amnio and epi and tubes and all the oxygen they could possibly ever want. And, oh, we got a 5-gallon bucket of IV fluid. Let's throw that in them too. The goal is to resuscitate and then maintain. And so we don't want to maintain with oxygen saturations of 100%. We want that 98, 99, so we know we're not hyperoxygenating. End-tidal CO2, remember our normal is 30 to 40. And so that's our goal post-resuscitation, is just breathing normally to keep their end-tidal CO2 30 to 40. And generally, I would say when you're bagging, if you're the person doing the bag valve mask, you're going to want to push it every 6 seconds, okay? And I mean that. Count to 6, which takes a lot longer than you think. When you're counting normally, you're not all jacked up. And you just breathe 10 times a minute, okay? And see how you're doing at that point, and that's normal for a person. And then obviously any kind of continuous monitoring you can do, whether it's constant rhythm assessment with your defibrillator, maybe even leave it in defib mode, don't charge it, and keep your finger on the pulse the entire time. I have in my career more than once, sadly, have had people delivered to me who had good resuscitation, good care in the field, had a great ROSC event, they got pulses back, they transported, and because somebody didn't have a finger on the pulse during transport, they deliver a dead body to me. And they come in pushing the bag with their endotracheal tube, which was the great focus. And what they didn't realize was that somewhere in transport, because they didn't have their finger on the pulse the entire time, they lost pulses again and therefore lost the patient. But because they had a rhythm on the monitor, PEA, and they had a bag they're breathing with, so they felt like the patient's breathing because they're breathing for them through the endotracheal tube, they deliver a dead body. And that's always a sad situation because you can just see the medic's mind of going, shit, because they realized they did a good job, they nailed it, they did all the stuff they're supposed to do, they got the patient back, and then lost it. And so that's a sad situation that I don't like to see, and I don't want you to have to go through that. So please, please, if you're the patient transporter, keep your finger on the pulse as much as you possibly can so you never have that happen to you, because that just sucks all around. Protocols, they make life simple when it comes to ROSC stuff and running resuscitation. So if your county doesn't have a good protocol already set up for when you have these resuscitation events, of just making it simple, of go through these steps one by one by one by one as a code leader, have one made. And if you don't have one available and you're kind of like, I don't want to just make one up on our own, they're available out there. Google it. There's going to be tons of counties with them. In Spokane County, we have it. And I actually think from a previous session, we posted ours in the EMSconnect uploads area. And so if you're looking for a great during resuscitation and post-resuscitation checklist and algorithm, by all means, go check that out, download it, use it, create your own. It's really cool because it actually has the 5 H's and 5 T's at the bottom of the pre and post cardiac arrest checklist. You'll see it there in the gray box. It's got some cool pearls. And so people put a lot of time into this here locally where I am. I did not have anything to do with this. I can't claim credit. And so it's people who are cooler than me in 2017 put this together and did a great job, or it was revised in 17. But this is just a great checklist. And so what I do recommend is if you have something like this, have a pre-ROSC cardiac arrest on the front, and right on the back, you laminate together the post-resuscitation. So you have one sheet for all cardiac arrest calls where you just have the code leader go through step by step by step. And if you get ROSC back, you flip it and go step by step by step. I mean, what a nice way to keep it simple. I love this thing, and I see people use it in resuscitations, and it's just a brilliant move to keep your life simple and to take a lot of stress away. So before I kind of finish this kind of first phase, which is the biggest phase, the second one will go pretty quickly. I just want to give you some of my tips if I haven't hit on all these yet so far. So I've worked in the ER as an attending physician for I think over 17 years now. so I'm getting kind of old. I hope I look young still. But some tips of where I see people bomb in these cases and where they could shine, okay? If there is no heartbeat, there's no blood moving, that means there's no oxygen to the brain, and you should be worried about the brain, okay? Push the blood. Don't worry about the tube, okay? People can bag, people can throw down an LMA or an SGA, whatever it is. Also, just doing compressions has been shown to passively ventilate a patient, which is why we now do hands-only CPR. If somebody goes down at the grocery store in front of me as an emergency physician, I'm not putting my mouth on theirs. I don't know where they've been, but I'm going to do compression-only CPR, knowing that they're going to get passive oxygenation from compressions, and that's been shown to be adequate. I'll go with that. Survival is a relative term. So when you get ROSC and that's all you're focused on and you just love ROSC, you even love saying those 4 letters, please remember that ROSC is not the be-all end-all of survival. It's having that patient send you a card in a few months and saying, thanks for saving my life. It's having that patient invite you to a barbecue to meet their wife, because not only did you have ROSC, but you provided such good care that you preserved brain function. That's when you feel like you really got into this job for the right reason, and it feels amazing, but it will be very, very rare, and it might never happen in your career, and that's okay, because a lot of patients are going to die during your career. Most cardiac arrests are going to die, okay? BLS saves lives. If you're a BLS provider out there listening to this and you feel like, oh, in a cardiac arrest scenario, what can I do? I'm just a BLS provider. First, pull your head out of your ass. Okay, you're BLS. You can provide just as good of resuscitative care as a paramedic when it comes to the science behind resuscitation. Good quality compressions and early defib is what saves the brain. And that's you. So get comfortable with this and enjoy a cardiac arrest. It's what you do, it's what you're trained to do. Intubation takes time and is a distraction, okay? Be careful of this, medics. Be very, very careful, because it happens way too often. It's becoming a pervasive problem, in my opinion. You're getting too focused on intubation, and you need to focus more on running a good code and taking control of the scenario and then intubating when you're ready and everything's working well for you. Cardiac arrest seems scary. This is for everybody. Cardiac arrest will always seem scary until you make that mental mindset of, I'm a pro and this is a cookie cutter scenario with checklists that I can run through. And that what's really scary is the patient's encounter and the family's experience through this. And so the people who are most scared are going to be the people you're there to treat. And if you're not paying attention to that, you're kind of missing the point and failing, even if you get the patient back. So be good to the people on scene, be good to your colleagues, and be very, very good to family or whoever's present, and help walk them through this really terrible time. Code leaders should keep a finger on the pulse. Hopefully I've beaten that dead horse enough. Know your role. I repeat, know your role, okay? Be professional. Leave your ego at the door, and this goes for all of you. The seasoned firefighter of 40 years, the paramedic provider who's got extra education in critical care. I don't care who you are, how many years you've been doing this. If you're an ass, you don't need to be in that room, okay? You're not doing anything good for anybody by being a jerk. You need to be a good mentor. You need to teach the younger people coming in how to run a good code, how to be a good mentor themselves, how to teach the next generation to do a good job, because people are watching us. I mean, with social media and phones, we're under the microscope. And so if you're arguing with each other on scene, and you're just generally being a total jerk, that just makes us all look like idiots. And it's not uncommon for me to have a family come in, post whatever event with EMS, and say something about EMS's behavior on scene. And I got to tell you, it's embarrassing, and you don't want that to be you, okay? They're going to remember it forever. So if you're that guy who's kind of an a-hole, it's time to do a real good gut check, good look in the mirror, and ask yourself, is this how I want people to think of me professionally? For kids, think it's going to be airway and breathing. For teens and young adults, it's usually going to be trauma or overdose. Adults, think heart, aorta, lungs, the usual stuff. And renal patients, it's potassium 99% of the time. Okay, last but not least, and hopefully I've already hit on some of these. You will not save everyone. In fact, most will die during your career. That's part of this job, and that's frankly the end of life for everybody. And I've yet to hear of an immortal person other than a cool vampire show. Okay, death does not equal failure. If you're running a resuscitation, and you're being a pro and you're doing the job you're there to perform, you should walk away from a resuscitation, whether they lived or died, feeling good about your job and what you did. There is something positive that you can do in that scenario. And it might have just been putting your arm around the patient's wife or husband and saying, I'm sorry for your loss, or this sucks, or whatever it is, okay? And just being there present for them during this difficult time and explaining the things you're doing and helping them process this, okay? Because even hospice patients, we've all seen this. You go and run a 911 call on a patient who's in the nursing home with DNR comfort care measures, and they call 911 for what? And it's kind of like, what do you want us to do exactly? Because they're DNR with comfort care measures. And so do your job, have your skills, and be a professional about it, okay? Be proud of the work you do. Enjoy and support the people you work with. Remember, fire, EMS, and police. You're not enemies. You're kind of all in the same category of first responders. And so if you find that you have a toxic relationship locally with your fellow professionals, you might want to address that real soon and really get a hold of that and find out what is it about each of us that, why do we have this animosity? I see it a lot between city fire department and a private ambulance company, and this one-upmanship of who's better and, oh, they're stupid and they don't do things right. And I just look at both groups and go, you're all idiots. If you can't get along as professionals for the same common goal of providing good patient care, then you're all failing, and I don't trust any of you. And so please be careful about that and stay professional. On a side note, take care of yourself. Okay, this job is stressful. We see and take care of some pretty nasty stuff that can mess you up in the head. Take comfort in the simple things in life. Find something you enjoy that's not a toxic behavior. I mean, it's not like alcohol or gambling, something that could be bad or damaging. Find those things you enjoy, protect them, turn off your phone, enjoy family. Okay, burnout is real. I felt it. Most of you who've been doing this long enough have felt it, and it can destroy everything in its path. So please protect yourself and take care of yourself. On that note, we can take a break.
Yeah.
So I'll try to buzz through this fairly quickly because really what I want is more time for any questions you might have. And that could be about resuscitation, ROSC, cardiac arrest, or really anything. Anything out there anybody's been having questions about lately, please start thinking about it, send it in. Got a case, a cool situation. Obviously, don't type in a whole bunch, so we got a huge amount of reading to do. But please, any questions? I love a good question session. You're here, I'm here. Let's have fun with this. So let's buzz through this and hopefully get to some question time. So some literature review I did recently found some pretty cool stuff, pretty interesting things. In Germany, in this year or last year, they did a study with drones delivering AEDs locally to people who call 911 with a cardiac arrest. Great concept, really cool concept, had some interesting dilemmas with it. So they had 50 out of hospital fake cardiac arrest scenarios, so these were not real. The limitations that I noticed with this, and I don't know anything about drones other than they're really cool, is that they had the flight paths from the base charging facility for the drone to the general area of where the resuscitation was going to be had to be pre-programmed, like a flight path. So that was a pretty big deal. And then interestingly, during landing, they needed pilot assistance, which then is like a no-go, right? If these aren't automated delivery to right where the caller is, until that point, it's crap. And so interesting, obviously there's going to be a future here with drones and social media and phones and internet capability and GPS stuff. Obviously, this is the wave of the future. It's just a matter of time till we're there, and it's probably going to be a short matter of time till we're at AED delivered by drones. Here's that cool case. Endotracheal intubation versus a supraglottic procedure in pediatric out-of-hospital cardiac arrest. Okay, so this is comparing intubation versus just throwing something in the upper airway. This was from Resuscitation in August of last year. It was done in France. And what it was a retrospective, meaning they looked in the past through cases to see, okay, let's find all the cases where we had a pediatric patient with a cardiac arrest who was intubated. Okay, and then let's find all the cases during this time of pediatric patients with a cardiac arrest who had a supraglottic airway. They took all that data, they went through it, ran it through analysis, and out of all the data, they had just over 1,500 kids. And 85% of those received endotracheal intubation, ETI, and 14% received a supraglottic airway during CPR. What they found in their observational study, okay, so this wasn't a study where they designed the whole thing only to look at this. So there's other factors involved, okay, we got to admit that. But what they interestingly found was a lower 30-day survival in the endotracheal intubation group compared to supraglottic airways. And that was like by double. So interesting. They did not see a significant association, however, between airway management strategy and ROSC. Ah, look at that. So ROSC is something we can get back on a lot of people if we just push hard enough, long enough, throw enough meds at, we can probably get the heart to kick out some electricity, right? Enough to cause a beat and we feel like, hey, we win, we got ROSC. That doesn't equal brain function, remember? The brain is the big deal. We get the heartbeat back, great. We care about the brain. And so neither of them, endotracheal intubation or supraglottic airway, had anything to do with ROSC. So that kind of proves it. Where should we spend our time? Good compressions and early defib, or endotracheal intubation and supraglottic airways? So this was pediatrics, so obviously they focused on the airway a lot, but they interestingly found a lower survival in endotracheal intubation. So then it brings up questions of, well, I wish we could have some follow-up data if we did a study specifically looking at this of, how long did it take generally to intubate with a tube versus to throw down a supraglottic? Was that statistically significant? A lot of factors go into this, but it's just interesting data that kind of goes along with our mentality of what do we want to focus on and spend our time on? Let's talk about epi. We got to talk about epi. Okay. Does epinephrine improve outcome? Let's talk about this again and again and again. So in 2009, blah, 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 did epi help? In Resuscitation Journal, 2011, did epi help? In 12, did epi help? In 13, did epi help? In 14, did epi help? Okay, in 14, Resuscitation Journal, American College of Cardiology, all these people, all of those articles, every one of them said epinephrine was consistently associated with a lower chance of survival with brain function. Okay, so basically epinephrine, the thing we use in every freaking resuscitation since 2011, over 10 years ago, it's been shown to not do squat for your brain and you walking out of the hospital after your heart stops. So why do we keep using it? Everybody's going to say, well, Dirks, don't you still use it? I do, and I'll tell you exactly why. Because if I don't, in this current litigious world we live in, and it's in the protocols that you give epinephrine and ACLS, and I didn't, and the patient died, could I be sued for that? I think so. I think there's this lawyer out there mean enough to go after me, even with all the information that's available and all the data, that would say, because I resuscitated a patient and didn't use epi or all the other drugs that have not been shown to do squat for people during resuscitation, because I didn't use something that was in the protocols, that I could be held liable. Maybe I caused harm because it's still there. And so yes, do I wish the AHA would take epi out of this stuff? Absolutely. Yep. Why they don't, I have no idea. So please don't ask me. And I'll probably get like death threats from the AHA just for having this talk. But epinephrine has never been shown to improve neurologic outcome. Will it maybe help your heart get back and get ROSC? Hey, yeah. Enough epinephrine, we could probably make you start jogging or something with your heart going after resuscitation. Enough epi will probably get the heart to start beating again. But does that mean that we've won the battle and that you're going to walk home and hug your kids again after your cardiac arrest? No. Epinephrine has not been shown to do anything. And in reality, several of these studies showed it actually caused a decreased chance of neurologic outcome at 30 days. So potentially it could be causing harm. So I don't know, we're all screwed here is really the reality, because until they take it out of protocols, it's still going to be recommended. So here's how resuscitation goes in my ER when I'm running it. I'll make sure that there's good compressions. I'll be watching the monitor. I'll be shocking as often as I need to for a shockable rhythm, and I will have my finger on the pulse the entire time. This is in the emergency department in a modern ER. That's all I care about. I make sure the compressors are not getting tired. I'm monitoring compressions, and there'll be a pharmacist behind me consistently going, Dr. Dirks, it's been 3 minutes since the last epi. Would you like to give another? And I'll go, sure, go ahead. Because it's in the protocols. It's because I'm supposed to. And do I like saying that I do things because it's protocol driven, even though I know it's no help? No, I hate it. I really don't like it. I wish I didn't have to do that because I've got resuscitation experts, cardiologists saying it's not useful, but we still give it. And I thank the AHA for still including it in their resuscitation protocols. Thank you. So Albert Einstein had a great quote about insanity. The definition of insanity is doing the same thing over and over and over again with expecting different results. So are we insane in this point? Probably a little bit. The basics, if you just push hard and fast at 100, 110 beats a minute, you minimize every pause in compression you possibly can, avoid intubating if it's going to delay your compressions. Rapid defibrillation if needed. If you have a shockable rhythm, shock it right away, okay? And immediately get back on that chest the second the energy is delivered, and you're changing performers every 2 minutes. You're doing the best medicine science has proven so far, okay? Those are the basics. Let's talk a little bit about AEDs because a lot of crews out there, especially rural departments, use AEDs, and these are phenomenal devices and have, really advanced rural care. So on this rhythm, okay, Sean, you can bring up the question number 5, but is shock advised for this rhythm, this kind of squiggly pattern? What do you think? So this is pretty classic ventricular fibrillation. The heart's just fibrillating. If you can actually see the heart doing this, it's really cool. Find it maybe on YouTube. There's probably a pig art or something doing it. Fibrillating looks like a bag of worms. It's really weird. It's just the heart's doing this. The muscle's just not organized. And so the heart muscle is organized where it should be atrioventricle, very organized, okay? Very organized. If you get fibrillation, it's just doing this. And so you can imagine there's no blood moving. There's no synchronized rhythm. There's no good synchronized compression happening atrioventricle. And so with this fibrillation, and we want to shock the heart, it's like slapping a naughty child. It's like slapping the heart, getting it back into a rhythm, kind of shocking it out of its state. Okay, so it's just fibrillating. It's not doing what it's supposed to. You shock it, it stops it, and then it's supposed to get it back into its regular thing again. So this is a shockable rhythm called ventricular fibrillation. Shock or no shock? And at the bottom there, it says there's no pulse with that. Good. So hopefully everybody can recognize that this is pulseless electrical activity. If there's no pulse and we see electrical activity, it just defined itself. Pulseless electrical activity. There's some sort of organized electrical activity, but I don't have a pulse, PEA. Okay, very straightforward rhythm. And this is when it gets those sad cases of people delivering me dead bodies. It's because PEA confuses them on the monitor. Somewhere along the way, they lost pulses, but the monitor still shows a great rhythm. That's the difference between electrical activity and cardiac activity where it's pumping blood. And if your finger's not on the pulse, you deliver me a dead body. That sucks. Shock advised or not? Okay. All right. Good, good. So 32% got it wrong. So let's take a look at this. So don't be confused by just the wavy pattern. This is actually classic asystole, and the TV shows always say flatline, right? If there's flatliners, everything else, they flatlined. In the world of medicine and people that are, people are bagging and breathing and the body's got, there's nothing's ever perfectly flat. It's never going to follow this perfect. If you ever see an absolute line across the page that's could be drawn by a ruler, it actually means your lead's probably disconnected. That's the only way you'll get a perfectly flat line on a rhythm strip, like a ruler line, is if you don't actually have a lead connected. And so try it on anybody, okay? If you're in asystole, it's going to be this you may even see tiny little ripples, okay? It shouldn't look like V-fib, but it's going to be this flat C, okay? There's just a bit of a roll to it. That's totally normal. So this is actually asystole. Totally fine. Everybody's asystole looks a little bit funky based on your lead placement, what's going on around the patient. Is somebody still bagging them? Because that'll cause some movement in the ECG rhythm. And let's see, shock advised or not, and with this, there is no pulse. So what is this rhythm and do we shock it? Good. So 83% got it correct. We do want to shock this rhythm. The rhythm is ventricular tachycardia. If we were going to actually march this out and pick a rate, we see over here on the left side of the screen, there's actually a QRS complex that lines right up on one of the lines. So we count this out to 300, 150. So it's between 150 to 300. It's closer to 150. So it's like 175. VTAC, usually I would hope it to be more around 180, 200, but it doesn't have to be. So this is most likely VTAC because there's no pulse. Okay, if there was a pulse with this and the patient's awake, could this be a wide complex like a left bundle branch block with a rapid rate underneath? Sure, okay. So not awake patient with no pulse, shock. This is most consistent with a VTAC in that case. Awake patient, I wouldn't shock this poor patient. They'll punch you in the face if you shock them when they're awake, number one. And number two, if they're VTAC and awake, we're going to treat that medically, awaiting for them to maybe pass out and we can shock them, okay? I might shock this patient if they're in awake VTAC, but only after sedation. So that's not something I expect you to do in the field. If you have an awake patient, keep them comfortable, keep them stable, put the patches on by all means, because the second they pass out from this and go pulseless, I'm lighting them up with a shock. And you're probably going to get them to wake up right away again. And it's really cool when somebody, head slumps, they go into a shockable rhythm, they're unconscious with no pulse, you shock them and they wake up and go, what happened? Those are rare cases, but they're a lot of fun as an ER provider and EMS provider. And if you're ever in that case, it can be not only a lot of fun, but it'll keep happening. They'll keep going into a VTAC or a VFib and you shock them and they keep waking up. It's super rare, but it's really interesting. You just keep doing your job, wait for them to pass out, go pulseless, shock them, and then get them to the ER. AEDs, so these are excellent option when you have limited resources, especially in those rural settings or small towns, especially if you have a BLS crew and you're not comfortable running a manual defibrillator. AEDs are fantastic. With AEDs, you're going to have a delay, okay? You're going to break that rule of constant compressions because the AED will say, don't touch the patient, analyzing. And it's just like this, come on, hurry up, we're off the chest. But that's just what you got to deal with, okay? And that's how the AEDs were developed. It's so that anybody, whether you're an EMTB, a first responder, a bank teller, whoever you are, it's that so you can just apply the patches, look at the picture, and it'll tell you what to do. It'll say, okay, do compressions, hold compressions, analyze. That's just how they're made. It's better than nothing, right? So don't rag on BLS providers or rural providers who use AEDs and their time off the chest is worse than yours if that's the level of training, okay? If the level of training is they're a volunteer farmer in their local community and the AED is the best they have, what you say as a medic when you show up as a paid provider dealing with a farmer who just ran a code at 3 in the morning with an AED and his time off the chest was a lot, what you say to them, thank you for helping. Thank you for showing up at 3 in the morning and doing what you do. This is amazing. Good job. Okay, that's all you say. Any other critiques, keep them to yourself, okay? You guys need to treat volunteer providers fantastically because if it wasn't for them, most of you people in rural America who go into cardiac arrest would die, okay? That's all I got to say about that one.
Hey, Travis, I'm going to ask you a question here because this is a perfectly a place to put this. This individual said, any thoughts on pad placement? And you and I had talked about this, right? He cited some research and thought it was pretty interesting about switching from the anterior lateral to the anterior posterior pad positioning. And then, of course, the idea of having 2 defibrillators with pads in 2 different planes. The research he's citing said it appeared to have higher rates of ROSC with ventricular fibrillation termination compared to standard defibrillation. Do you have any thoughts on pad placement or any experience with that?
Yeah, great question. So I just talked about this recently with one of the residents in the ER. So pad placement for me is just anecdotal. I don't know the science behind it, but this is what I found works well, and it just makes sense to me in my head. If I have a skinny patient, a normal body habitus to skinny patient or a child, you want that electricity. I'm going to zoom down on my heart here a little bit. Yeah, there you go, sexy shot. You want the electricity to go from the I'm going to point to it properly. Hopefully this is proper on your screen, not backwards, but my atria is up here and my ventricle is down here. So my heart's sitting in my chest here, atria, ventricle. And the natural conduction for the electricity in a person's heart goes from the SA node, travels through, okay, AV node, and down to the apex and spreads around the ventricles. And so in every patient I have that I'm going to be shocking for some reason or another, I want the electricity to follow the most natural path from A to B. And so the best way I can do that in some people, if they're skinny, I try to go directly through the heart from here to the back. And so like a vector pointing straight through from the SA node to the back. And so on low body habitus people, skinny people, thin people that I can easily maneuver, roll around and lift up, I'll put a patch right here over just over the right side of the upper sternum to get that SA node. And the other patch I'll put directly behind their back right here so that I get that electricity to shoot through like a vector right where I want it to go. If I have a big patient, if I can't roll them, if it's going to be just a nightmare to try to roll them, if they're morbidly obese or lift them up is impossible because they're unconscious, I don't blame you if you can't get a patch in the back. It's going to be a nightmare trying to place it and lift them and move them. It's going to be really difficult. So what I'll do is the best next option is a pad here, the same place every time on every patient. First patch here, SA node, and then I will go as far lateral and down as I possibly can so that my vector electricity travels from here as close to that vector as I can possibly get of natural flow of electricity. So that's my 2 cents on pad placement. And that's for everybody. And you know, AFib, people we cardiovert out, same exact thing. Every patch placement is the same, no matter what I'm doing shock-wise, whether I'm cardioverting or defibrillating, VFib or VTAC. I always try to do that. So the best option is front to back, right to left. Second best option, if they're too big, is just same first and really far lateral as you can get. The second question about the dual shock thing is kind of this new science stuff, doing a dual synchronized defibrillation, meaning 2 monitors set up, 4 patches set up, and either one person with their finger on both buttons or 2 people who pushing the defibrillation at the exact same time for what's called a synchronized dual cardioversion or defibrillation. I have yet to do it in my career. I'd probably start somebody on fire. We'll see. So let's talk about automated compression devices, okay? These are really cool. Actually, I've played with both of them. There's a few out there, but I have no financial interest in these companies. I have a crew here that I work with in Cheney, Washington that uses a Lucas device, and I think they love it. I think it's really cool. I've played with the Zoll device as well, but I don't have a crew that uses it. And so they're really cool devices. And where I think these come into play immensely helpful is for those rural departments or small departments where they have just 2 or 3 people responding to resuscitations or cases in general. And this takes the role of basically 2 people out of the scenario. So you could show up as a crew in a cardiac arrest, get compression started while your buddy gets the Lucas or the Zoll auto pulse, gets it ready and gets it set up so that when you're ready for your 2-minute check, you throw the thing under, you get it set and you get it going, and that's your first pulse check. And then you set it and forget it. And these things are amazing. And they just buy you time. And now you've got 2 providers who can basically stand back and become helpful in other ways. And so I personally love these devices if used in the right setting. I would frankly like to have one in the emergency department. We don't, and I think it would be lovely. I would love to use one in the emergency department, but I definitely like them for crews that have few people or need the extra hands or have decreased staffing. And these days that seems to be a big problem. So here's the Lucas device in the right, and you can get it in this backpack, hard case, carrying case. There's the auto pulse in the middle. And then we have the thumper on the left. And I don't know much about the thumper. I've played with the Lucas and the auto pulse, and both seem to be extremely usable devices, okay? And everybody, depending what they've used, has their critiques of everything. I won't go through them here because I'm not here to sell you either one of those. These automated compression systems are really, really good time savers, but they raise the question of, you know, could we transport with compressions in progress if you've got one of these automatic compression devices? I would still advise against it. I think you should run a scenario on scene, albeit, not counting peds here, okay? Adult normal resuscitations. And if you don't get pulses back on scene during your resuscitation attempt, I don't think we should be transporting those people. I don't want you delivering a dead body to the ER, because now what am I supposed to do with a dead body? They're taking up an ER bed from one of my people in the waiting room who needs emergency care. So you've delivered me basically a paperweight. Yeah, I'm sorry, but that's like, let's get down to the business of medicine. What am I going to do with the dead body? Which is why I don't want you transporting dead bodies. I want you running a good resuscitation in the field, doing compressions for people who don't have these automatic things. Doing compressions has been proven time and time and again to be very ineffective in a moving vehicle. You don't do quality compressions, so that's worthless. And if the patient passes away on scene, that's an appropriate time to involve law enforcement or a coroner to see if this is it a crime scene? Does something need to be investigated? Does an autopsy need to be performed? And so I want you to run a quality code on scene. If you get the patient back, bring them to me and let's see if we can keep things going, see if there's something we can do. But everything you do in that first 10 minutes is critical. And so I want you to focus on doing a really good job in those first 10 minutes and doing great quality care, good compressions, early defib. If you get them back, please bring them, but please don't transport a patient with compressions ongoing. I just don't think that's quality care, and I don't think it's helping anybody. These are good for extended resuscitations. Let's say you do have that cold water drowning and they're not dead till they're warm and dead. This is when you would bring them in with an auto pulse or something going, okay? Put that Lucas device on them, get compressions going, start warming and bring them in. That's appropriate. Those overdoses where it's like a beta blocker overdose and you might not have a good cardiac function for hours until the medication wears off. Okay, that's something. Call in, talk to us medical control and go through your thinking. Maybe we will say, okay, transport with resuscitation and compressions. That's okay. So there are cases, just communicate with us, call in if you need to. Here's a little piece of equipment we talked about actually quite a while ago. Dr. Ernest talked about this, the rescue pod. So for those of you who have heard of this, it's called an impedance threshold device. And really the point of this is that you can use it with a bag valve mask or after an endotracheal tube is down. And what it's doing is it's preventing that exhalation during a resuscitation to try to decrease the intrathoracic pressure so that you actually get more venous return. And so more venous return equals better cardiac output. So that's the gist of it. I'm not going to go through the science of it, but it's been shown to be beneficial in resuscitation. Just going to throw that out there. And there's a little bit more about it. I won't go through it, but this has been around. I mean, this data was done in 1998, so it's been around a long time. And then we have end-tidal CO2. Very, very useful in resuscitation. It's something I think all of you should feel comfortable doing with resuscitations. If you're not comfortable, start using it and get yourself comfortable, get some education. We have plenty of it out there on this. And really remember that goal of end-tidal CO2 during a resuscitation is 20, over 20. If you call me and say, Dr. Dirks, we've got this resuscitation we've been running, I'll say, how's your end-tidal CO2 been? It's been around 5, 10. It kind of tells me, well, the resuscitation quality of compressions may not have been as good as it could have been. Maybe you needed to do better compressions longer to get that end-tidal greater than 20. I don't know. So it's a good marker of quality CPR. So start using it. It's really advantageous. So this is just a quick thing of, on the left, we have good end-tidal CO2 readings where it's coming up to 40. That's great. This is apparently an endotracheal tube is down the throat and we're breathing through the endotracheal tube and then all of a sudden we lose our waveform. Well, what happened? This is kind of a classic look of end-tidal CO2 tells you immediately if you've lost your tube. And so end-tidal CO2 is really, really useful for monitoring lots of stuff. If the patient loses pulses again, your end-tidal CO2 start tanking, okay? If you lose your endotracheal tube, end-tidal CO2 is immediate readout of perfusion. And if you get return of circulation, you might see a washout where all of a sudden your end-tidal CO2 goes from 20 to 50. And you're kind of going, why? Why is our end-tidal CO2 so high? And then all of a sudden somebody's like, hey, I feel a pulse. So that's probably it.
Any thoughts on head up CPR or raising the patient's legs?
The whole point is just to increase venous return, kind of like that rescue pod is doing. And so I don't think it's out there as proven science of helpful, but if you're going for increased blood return, maybe, you're talking about a septic patient or hypovolemic, somebody who you think might be in a shock state and you want some fluid return, sure, if you raise their legs, you're very likely physiologically going to increase their venous return and thereby improve your cardiac output. So it's something that you can do if you have the time to do it. It's fine. The whole head up thing, usually during resuscitation, I want somebody on kind of a hard plate on the back, just for the quality of resuscitation. Don't ever try to push on a patient's chest on a couch or a bed. You're just going to have a bouncy patient, and you're actually not pushing on their chest at all. You're just pushing the whole patient up and down. And so move them onto the floor, move them onto some sort of harder surface where you can do quality CPR. So that's one thing. After I get a patient back, if I get return of pulses, or there's a tube down, or I'm trying to bag breathe for them, I will usually elevate the head of the bed just a little bit. There's nothing more behind that other than me trying to avoid a potential aspiration event. If we keep a patient flat, if we don't have their airway secured, I always assume everybody just had a Big Mac at McDonald's an hour before I got there. And so I don't like having flat people after I get a heartbeat back. I like to bring the head of the bed up a little bit. It's purely out of my nervousness about, I've got a good patient. I don't want to now cause a second problem of letting them aspirate something if they regurgitate or vomit. I want to have them kind of up a little bit just to help prevent it. But that's purely anecdotal, no science behind that.
Perfect. Your next one, for obese patients where finding a pulse on a normal day would be difficult, do you have any suggestions on how to approach that during a code?
Absolutely. Don't be afraid during resuscitation, family present, wherever they are, to get the pants undone, get the pants down, cut them if you have to, and then you have a buddy grab the belly, okay, grab the pannus and pull up the pannus, all the skin flap, because a patient's groin, where their femoral artery is, in everybody is actually, there's not a lot of fat there. The inguinal area where the femoral pulse is a normal place for there to be folds over, but it's not a very obese area. So usually if you can get to a patient's groin, that inguinal canal, and I'm not gonna stand up and show you mine, I just think that's inappropriate. But if you find that area and you just pull the tissue up and pull the fat up, and you can pull in there and you can just go kind of reach through, and you're going up and down from the groin to kind of the hip area along that canal, along that crease, you can find a pulse. And so really you just got to be a little bit less gentle and get the fat pulled up and find that pulse. And I go for femoral in everybody. I don't go for carotid because there's too much going on up here. Movement, I can never find a good carotid. I don't do radial because it's too far away, it's too small. Maybe they had a previous surgery or trauma, and it's still, we're moving around, we're doing IVs. I go for femoral because it's a place I can stand out of the way, find a pulse on nearly every human being ever created. No matter what procedure they've done in the past, there should be a femoral pulse, aside from the LVAD. LVAD patients don't have pulses, remember.
Next one, what are your thoughts on the precordial thump?
Oh, gosh, there's some fun ones out there. I love this stuff. So the precordial thump, I've done it once, and it was really fun. The only time I would ever do a precordial thump, and again, be careful of your protocols, okay? If you have a medical advisor who's covering your butt, who's putting their name on your charts, and they're not cool with you doing a precordial thump, don't ever do it, okay? Don't ever break that, no matter how fun it might be or cool. The only time you ever do a precordial thump is if you see a patient go from talking to you to unconscious and no pulse that second. You witnessed it.
I missed a step. What a stupid mistake.
You fell right. It was an accident.
It was burning.
VTech, no pulse.
Start CPR, Baggin. Which one would that be?
Charging at 200.
Or that works too.
Thanks. Had it.
At that point, withoed any AED or defibrillation available, if you, boom, one quick bang right on the sternum, if you're lucky, it's just like those news cases where a person gets hit with a soccer ball in the chest and goes into a VFib arrest immediately. It's the same thing as a precordial thump. They were hit right at a precise time in their electrical activity to cause their heart to go into a different rhythm. So that's the whole point we do with a precordial thump, is the luck of potentially getting them right in the middle of a cardiac rhythm to jolt their heart out of it. That's the point of a precordial thump. There's nothing more scientific about it. I've had a couple nurses tell me, kind of old school nurses who've been doing this a long time, they've been successful having it done once. I don't know if it's true. I also heard a case of a cardiology resident in training where I trained who, was cardiology resident, was waiting for their chance to do something like this, saw a rhythm outside of a patient's room on a telemetry monitor in the hospital, and it was a shockable rhythm. He ran in the room and smashed this guy in the chest as hard as he could, and the guy slugged him in the face as he was reading the newspaper. And so be careful about acting on things if you don't know all the details. Don't ever shock a patient or hit anybody who's awake. That's just a rule, a basic rule of EMS.
I like it. The last one that's still pending is, you didn't talk about pre-charging prior to the 2-minute check. What are your thoughts on that?
If you can, if you have a defibrillator in manual mode and you're comfortable with it, again, everything about resuscitations needs to be that you're comfortable doing this. You've done it like a million times, you've practiced it a bunch of times. The perfect resuscitation, in my opinion, is the least amount of pauses and compressions. So my perfect scenario, if I'm the code leader and my finger's on the pulse, is that we've paused for compressions. That second, I know there's no pulse. I see the monitor. And in that second, I see either VFib or VTAC, okay, the two shockable rhythms, the only two shockable rhythms, by the way. And I immediately say, continue compressions. Okay, so now I've got compressions going again. And now I say, charge the monitor. And they charge to 200, because I go big or go home, baby. Charge to 200 biphasic. When it's charged, I tell everybody, right, we're going to pause just for a second, shock, and I want you back on that chest immediately. Don't wait for anything. And then we go, okay, pause, shock, boom, back on the chest. So my whole pause during that whole time was the 1 second rhythm check, pulse check, and then the 1 second shock delivered. Nothing more. Other than that, we've been on the chest the entire time. So if you have a defibrillator that you're comfortable running in manual mode and you know your rhythms and you know how it works, absolutely, compressions while charging are fantastic. But if you're not a provider who's comfortable with that, you don't know your defibrillator well, you're not comfortable calling a shockable rhythm, or you just have an AED only, it's not an option. You can't charge, you can't do compressions during charging. It's going to say, don't touch the patient, don't touch the patient. And if you start compressing, it might pause the charge.
This one, also another fun one, no time to Google this one. In blank, Peter Safar, an Austrian physician, and Osmund Lerdahl, a Norwegian toy maker, created the first CPR mannequin. 1958, 1994, 1925, or 1940 are our answer choices. So we'll see what people come up with this one.
I didn't know Lerdahl was a toy maker. That's really
Me
interesting.
neither. When I looked this up, I was like, oh my gosh, it makes so much sense. What would you have guessed? Did you have a guess?
I mean, I would have probably gone with pretty early 40s or 50s.
Yeah, so it is, like, again, this was just straight from Google. 1958 was when we had the first CPR mannequin, which was kind of crazy. Kayla Carpenter, congratulations. We will be sending you an email and get your information so we can get that sent out to you. So congratulations. Last another throw in there is our podcast. Check it out on all those major podcasting platforms. Download our episodes. Let us know. In fact, tonight we had someone message with a great podcast idea. He doesn't know it yet, but I'm going to rope him in to be the guest on it. It's going to be a tough topic. I don't want to give it away, but I think it'll be something we'll all want to hear about. Travis's episode on professionalism and burnout, I guarantee will be career changing. That's going to drop that first week of February, and we got some great episodes up already. One, in fact, from a EMS-centered psychologist out of Texas talking about EMS providers' mental health, and it's phenomenal. So check that out. I really appreciate all the feedback on that. The podcast is called EMSconnect on Shift. If you just look up EMSconnect on any of the major podcasting platforms, you can find that. As always, again, you got questions, comments, anything along those lines, info@emsconnect.org, or you can reach out to us on social media. We're super responsive, answer questions. Facebook, Twitter, Instagram, any of those. Let us know if you've got questions, feedback, episode ideas. We'd love to hear from you. As always, I know I speak for Dr. Dirks, but have a great night, everyone. Please stay safe and healthy, and we will see you guys in February.